Now, I promised we were going to shift this way because there's all this interesting stuff, 95% better than others, statistically better, clinically better. Where does the money fall? These are not cheap drugs, are they?
No, they're not, and they're all expensive. I mean, as we look at the reality of what are these priced on an annual basis, and now we have a plethora of options. You know, we have an explosion. Let's look at, you know, the facts. We have many, many different options now. Besides IV, oral, sub-Q, we have different mechanisms of action, different frequencies. You know, it's amazing to me that we can think about now going from something where you have to take it every day to once a month, every 6 months, to now the option of for 2 years and maybe nothing thereafter, or 8 to 10 days, you know, a year over 2 years, and then potentially, you know, remission, can we call it? So on the payer side, it's a bit of an enigma in terms of how do we think about, given all these options and given what we know about the biology, I think we recognize that we need choice, but do we need all of them? And I think that's probably where you're going next, is what does a payer do,
What do you do
with
exactly?
all these different options that exist? And in a world where there is still uncertainty about the disease, the progression, how do you match right patient, right choice to get the best outcomes?
If you've only got one ICD-10 code, that's going to be tough to begin with. And the question really to me is, am I about to hear from you step therapy, start with the traditional cheap stuff, or am I about to hear this stuff is so good, go right to it because you've got a 6-month window?
Yeah. Well, I think it actually starts not with ICD, but it starts with the label indication for a therapy. And I would argue that most payers are not in a position to challenge a neurologist or an MS specialist to say, you don't have relapse MS, you have secondary or primary progressive. We are not the experts, nor is there a biomarker. So usually the prior authorization, the appropriate and the medical necessity use of the drug begins with a label indication, and we're going to rely on clinicians in terms of defining what type of MS does that patient have, as well as perhaps an understanding of what else they've been on. One of the things we are doing more in terms of managing, particularly the IVs, is the site of care. Because in addition to the drug cost, where the drug is infused has a lot to do with the end result in terms of the claim, the total cost of that claim that we're going to be paying. So the same drug in a hospital outpatient versus a physician's office or infusion center, big difference.
So you may approve this expensive drug. By the way, how much are we talking? What are the numbers like?
The band usually is going to be anywhere between $60,000 to over $100,000 per year.
Per year?
Per year.
Per patient?
Per patient.
This is serious money, all right?
Yes.
So what I hear you saying is we need to control some aspect of this in order to make sure that the patients who get these drugs, if we approve them, are at least going to get them properly and get the best chance for success. So maybe you're going to limit the sites at which they can be administered, yeah?
Well, also I think looking at the reality of what, you know, has lost patent, Copaxone, for example, right? The ABCR drugs, amongst them Gladimer, right? That's now, you know, a fraction of the cost of perhaps other alternatives. And what this also means for patients in terms of the reality of what they may be paying for, copay, co-insurance on a monthly basis, and then their affordability, which reflects on compliance, and if they're not taking the drug, it's not going to be effective. So these are all things that in the context of, I think, value, right? What is the role of these treatments? What is their indication? What do we know about their efficacy? Who are they appropriate for? And, you know, the reality of new options, but also existing options that may be going off patent.